First of all, I'd like to express my sincere appreciation to Amy for inviting me. I must tell you that about strokes from a family practice perspective. And I don't want to so much dwell on the pathology of strokes as I do on some of the common causes that I see in my medical practice. I practice in Charleston, South Carolina. My practice is probably 95% African American, and so a lot of the common issues that I see that relate directly to stroke I'm going to talk to you about. And then I'm going to share with you some of the common barriers, particularly that I see with African American patients. And I'm going to share with you some of the things that I have done through Closing the Gap in Healthcare to help dispel a lot of the myths and untruths that we see, particularly among African American patients, but I'm sure that some of the myths that African Americans present with, other patients present with too. These are the chronic medical conditions that I see in my practice every day that relate directly to stroke: hypertension, diabetes, obesity, elevated cholesterol, sedentary lifestyle, smoking, chronic alcohol abuse. All of those issues relate directly to stroke in the patients that I see. We'll discuss them individually. Well, first of all, you all should know that diabetes increases the risk for stroke, and that brain damage may be more severe and extensive if the blood sugar is high when a stroke happens. One of the things that I try to do in my practice is I try to break down the complicated medical issues and explain them to patients in a way that they understand. In Charleston, we refer to strokes as sugar. I guess, I don't know, y'all refer to it as sugar down here? Well, we refer to it as sugar in Charleston. And just several days ago, I did a health tip and talking about how sugar is poisonous to the system. And of course, we'll talk a little bit about that. So here again, that's just a way of taking a complicated information and explaining it to people in a way in which they understand. I was online kind of looking around, trying to find some new pearls about strokes yesterday. And one of the things that I found, and I've certainly found this in my practice, and that is, in spite of all of the medical information that we have about strokes, people still have strokes because of a lack of information. I don't know whether or not you found that in your clinical practice, but people just do crazy things, and they just don't have good information. And so as a result, we are seeing more strokes, particularly strokes that are related to, that are in young people. I don't know whether you're aware of it or not, but the prevalence of strokes is increasing in the younger population between 30 and 45. We are seeing a lot of strokes that we didn't see years ago. We usually thought of strokes years ago as occurring in people 65 and above, but that's not what we are seeing today. And diabetes contributes to that significantly. Okay, I want to talk to you a little bit about diabetes control and the importance in preventing strokes. First of all, the importance of the A1C. I'm impressed with the number of patients who don't have the slightest idea what their A1C is. I assume, maybe that's an incorrect assumption, I assume that for those of you who are listening to me, you understand what an A1C is. It is the test that we use to make the diagnosis of diabetes. We can tell whether or not your diabetes is under control, and we can tell whether or not you are in the grace period. And the grace period is your diabetes is really not high, but it's really not, it's really not low enough, but it's really not high. It's kind of like in the grace period. Of course, the other thing that, that family doctors don't do a good job of, but I recommend that family doctors do this, and that is recommend that all of their diabetic patients receive diabetic counseling. When I was in medical school, I did not get a whole lot of information about diets. I probably learned more about diets in the past 10 or 15 years. But one of the things that I did, I attended a dietary session, and of course, I can tell you that family doctors don't have the time, and we don't have the background to be able to discuss all of the nuances that need to be known when it comes to diabetes. So I send all of my patients to diabetic teaching, and I find that patients who don't have diabetic teaching are not going to do well. And here's a piece of information that you may not know. Insurance companies do not pay for our patients who are pre-diabetics. I know you may find, I found that to be very interesting, that insurance companies do not pay for pre-diabetics. You already have to have the disease. I send a lot of my patients to St. Francis Hospital in Charleston, and of course, the cost for getting diabetic training for pre-diabetes is about $50 to $60. And of course, when I tell patients that they are right in the grace period, and for $50 or $60, you can go to St. Francis Hospital to get diabetic training, to get dietary training, that's not a problem for most patients at all. The importance of daily exercise. I am impressed with how daily exercise is not embraced by the African American community. I still have a major problem getting people to understand how important it is to exercise for 30 minutes a day, 4 to 5 days a week. And we'll talk a little bit more about that. And then, of course, the importance of taking your medications daily. I cannot tell you the number of patients who think that you can take your blood pressure medicines 2 or 3 times a week and your blood pressure will remain under control. Just the other day, I saw a patient who let his medications run out, and he came in and he was flabbergasted when I told him that his blood pressure was elevated. And he said, well, but I've been taking it, I just let it run out for a week. And I had to explain to him that these blood pressure medicines only have a lifespan in the body of about 22 to 23 hours. And so he said to me, you know, you need to do a health tip about that, because most of the people that I know do not appreciate the fact that blood pressure medicines only have a lifespan of that long. And so I would encourage you to make sure that your patients understand that you tell them that the medicines have to be taken daily. And then, of course, I don't know whether or not you experience this, but certainly in my practice, I experience what I refer to as the insulin dilemma. Nobody wants to be put on insulin. And in fact, many African Americans will tell you that when their grandmama got put on insulin, they had to cut off her leg 2 or 3 days later. And I hear that all of the time with the patients that I talk to. And patients do not understand that if they are diabetics and if they live long enough, at some point in time, the pills are not going to work and that they are going to be on insulin. The other thing is that they want to know whether or not they're going to be diabetics all of their life. And I have to give them the news that in most cases, you will be a diabetic all of your life. And then, of course, the importance of taking what I refer to as the best blood pressure medicines. There are some medicines that we know, particularly in the African American population, don't work as good as other medicines. And I find this to be particularly the case with African American men. I see a lot of African American men coming into my practice on big dosages of beta blockers. And of course, they have stopped taking the medication. And the reason that they have stopped taking the medication is because not only does beta blockers make your blood pressure go, but they also cause erectile dysfunction. And so a lot of black men will tell you that I don't want to take these medications because it will cause me difficulty getting an erection. And of course, that's a common myth among many African American men. I think you should have that discussion with them. You should let them know that there are medications that they can take that will not cause erectile dysfunction. So that's very, very important. All right, these are steps for keeping the blood pressure in the safety zone. I was talking to a lady yesterday. Her blood pressure was extremely high. And she said, well, it's just a 150 over 110. And so I asked her, did she know what a normal blood pressure was? And of course, she didn't. And you will be impressed at the number of people who do not know that anything above 140 over 90 is not good. And that the data clearly shows that your chances of experiencing a bad outcome is increased when the blood pressure is greater than 140 over 90. So you need to make sure that your patients really do understand that. Of course, we all know the importance of reduced sodium and explaining to patients that sodium causes blood pressure to go up and that African Americans are salt sensitive, and so therefore you should try to stay away from salt. One of the things that I talk about and encourage all of my patients to get is a blood pressure monitor, because there is something called white coat hypertension. White coat hypertension, when the patient comes into the office, blood pressure goes extremely high. It makes it look like the patient is not being very, very well controlled, when really just the anxiety of being in the doctor's office will cause the blood pressure to go up. So sometimes we have to have those patients sit down. I play a lot of jazz in my office, listen to some jazz, look at television, and hopefully we'll check your blood pressure again, and hopefully that blood pressure will be down. But what I do is sometimes the blood pressure doesn't go down, and these patients are they tell me, I'm taking my blood pressure medicines just like you say, so I recommend that they get a blood pressure monitor, take their blood pressures at home, bring the home blood pressures into me, and that's what I look at when I'm trying to decide whether or not the blood pressure is going to be under good control. By the way, the monitors that you put on your finger are not accurate, so I don't use those. The monitors that you put on the wrist, I found that those are not accurate. It's the monitors that you put on your arm. And sometimes patients will tell me that their blood pressures, when there's a big discrepancy, I even have them to bring their monitor in, and we check their monitor against our monitor. We have several of them. And of course, it's not uncommon for them to have real cheap blood pressure monitors, and they're not working as well as they should. So monitoring blood pressures at home is very, very important. One of the things that very well may not be appreciated is the effect that alcohol has on the blood pressure, particularly in the young men that I see. I see a lot of young African American men in their 20s, 30s, and 40s, and they drink a lot of beer. And they are not aware that if you drink a lot of beer, you drink a lot of alcohol, that in itself can cause your blood pressure to be elevated. And oftentimes I will ask them to stop drinking not put them on any medications, just ask them to stop drinking, no beer, no alcohol for the next 2 weeks, and then come back in. And I'm really impressed with the number of men whose blood pressure will go back down to just from drinking too much. And then, of course, while I don't try to give patients diets, I do recommend for patients that they look at the DASH diet. Most of my patients are computer literate. They'll go look at the DASH diet, and the DASH diet is one that I'd certainly recommend, not only for folk who have high blood pressure, but just as a good diet in general. I recommend that you Google the DASH diet, and you'll see what I mean. Another thing that I see that's very, very common in my practice, and that is patients do not appreciate the fact that they have to be on more than one medicine. Sometimes they get very, very upset when you have to put them on more than one medicine. In my practice, the average medicine for patients to be on for high blood pressure is 3 pills, is at least 3 pills. And I have some patients who are on as many as 5 medications. The problem that I run into with people who are on 5 medications is that they will run out of 2 of them. And they will just continue taking the 3, and then they will think that their blood pressure is going to be under control when that's not the case. So you have to really preach to them that I'm putting you on 4 medications. You got to take all 4 of them every day in order for the blood pressure to be under control. And of course, here again, I do point out to patients that exercise is medicine, and that if you exercise on a regular basis, you won't make your blood pressure go away, but you will put yourself in a position for your blood pressure to be under fairly good control. Because a lot of patients do have the perception that if they lose weight and if they exercise, then they won't have hypertension, and of course that's not the case. I'll give you a case study in just a few minutes about that. So the take-home point is that blood pressure is above 140/90 is not good. It was reported, and it has been reported, that even a lot of physicians think that if you just get close to 140/90, that's good enough. And of course, a lot of the medical data now is suggesting to doctors that they really should do a better job in getting patients under 140/90. In fact, just an article came out about a week ago saying that about 75 million people in the United States have high blood pressure, and about 1/4 of those who are on medications are not under very, very good control. And that is because doctors just don't do a good job in making sure. Just yesterday, I saw a lady who had already had a stroke. I do disability exams for the disability board, and I saw a woman who had had a stroke at age 61, and she was 3 months out from her stroke, and still her blood pressure was not at goal. It was still too high, and she was thinking that it was. So I encourage her to go back to her physician and say to her physician, look, my blood pressure is really not under control, and my risk for having another stroke is very, very high since that blood pressure is not under control. So I've already mentioned hypertension and alcohol. Let's talk a little bit about strokes and smoking. I've just pulled out some statements that you may want to jot down and try to remember when you are talking to patients who smoke. I don't think that patients really appreciate what smoking does and how it sets them up to have a stroke. The chemicals in cigarettes damage the wall of the arteries, resulting in a buildup of fatty plaque that can harden and narrow the arteries, restricting the blood flow to the brain. And so I don't use words like fatty plaques. I just said think of the think of your arteries like a pipe, and sludge is in the pipe. And when you smoke, you increase the sludge in the pipe. And this is a concept that a lot of people can appreciate. You increase the sludge in the pipe, and when the sludge increases in the pipe narrows, and as a result, blood flow going to the brain or to other arteries is decreased. And so most of the time, patients get that. Smoking makes the blood more likely to clot. These clots can travel in the bloodstream until they finally become stuck in one of the blood vessels in the brain, cutting off blood flow and triggering a stroke. And strokes and smoking in men and women. Is smoking more harmful to women than men? Well, when it comes to heart disease, smoking is more harmful, but in strokes, it doesn't appear to be the case. And strokes stroke risk increase in women who take birth control pills. Smokers also tend to have a high level of bad cholesterol and triglyceride levels. And of course, I try to explain to patients that there are two kinds of cholesterol, good and bad cholesterol. And as a result, a reason for taking your cholesterol medicines is to decrease your risk for having a stroke. And some of them get it. I'm really impressed with the number of people who get discharged from the hospital who are not on cholesterol medications. I'm really, really impressed. And they get discharged from oftentimes from cardiologists, by cardiologists, or from the hospitalists, and they are not on cholesterol medicines when we clearly appreciate that cholesterol and statin drugs decrease one's risk for having a stroke. Can exercise prevent stroke? And I think the data clearly shows that exercise is medicine. Stroke is just one of the things that exercise can prevent. And the data clearly shows that even if you have a stroke and you have exercise, then your possibility of recovering from the stroke and having the stroke not be as devastating to you is improved if you have exercise in your background. And of course, we've already talked a little bit about bad cholesterol and good cholesterol. And even now, in my office, we are doing even a little bit more. We are taking a look at particle size and particle numbers, and we are addressing those issues as a way of decreasing stroke and heart disease. Now, I hope this is going to work. As I told you, one of the things that we do in Charleston, if you come to Charleston and you listen to 107.3, you will hear me on the radio probably about 8 or 9 times a day. And I write these health tips. And these health tips are written in such a way that patients can understand them. Some of them are funny. They are very ethnic, so they're written in a way in which African American people and other underserved populations can understand them. We recently got a grant from the Medical University for $100,000, and this grant is going to look at closing the gap in healthcare to see how effective we have been over the past 7 years in increasing the health literacy of primarily African American patients as well as the underserved.
And now, Closing the Gap in Healthcare with Dr. Thaddeus John Bell.
Am I too young for the flu vaccine? It has been difficult to convince young African American people to take the flu shot, my own family notwithstanding. This year, the CDC recommends the flu vaccine for everyone over 6 months of age. While younger people are less likely to develop complications of the flu, it is still recommended. College-age young people who experience flu-like symptoms are reported to do poorly on exams if they have the flu. Remember, African Americans have a high prevalence of chronic medical issues, and without the flu vaccine, we are at high risk or complications and death. I'm Dr. Thaddeus John Bell, closing the gap in health disparities for African Americans and for the underserved.
And now, closing the gap in healthcare with Dr. Thaddeus John Bell.
Cephus, the last time we talked, I told you that somebody said your girlfriend might be HIV positive. Now, did y'all sit down and have one of them discussions about HIV/AIDS? You need to tell that girl y'all need to be tested before y'all have any more relations. Now, I would recommend that you have a good talk about having an HIV test done. Now, don't put a lot of pressure on the girl, because she might run away. But if she run away, you better run too and get yourself to that doctor's office. Tell her about what you're worried about, Cephus, because it's both of y'all having some of them SUVs if you don't watch yourself. Let her know you're going to have an HIV test done too before y'all have any more relations. Make your first date, Cephus, to the doctor's office. Go get tested.
I'm Dr. Thaddeus John Bell, closing the gap in health disparities for African Americans and for the underserved.
And now, closing the gap in healthcare with Dr. Thaddeus John Bell.
Men's sexual health. Here are a few tips that all African American males should use to help protect themselves and others from HIV and other STDs. Condoms should always be used when having casual sex. Know as much as possible about the history of your sex partner, male or female. Men who have sex with other men are likely to give HIV to his female sexual partner. Recognize that you can get an STD through oral and anal sex. If you have genital herpes, the affected person must protect the unaffected person by using condoms and taking medications daily. If you are having sex with more than one woman, you need frequent HIV and other STD surveillances. I'm Dr. Thaddeus John Bell, closing the gap in health disparities for African Americans and for the underserved.
And now, closing the gap in healthcare with Dr. Thaddeus John Bell.
People act like traffic lights. People who have medical problems often act like traffic lights, making it difficult to do the right thing by them. Some folk are like red lights. They will not move no matter what information is given to them. These folk will have major medical problems and in most cases will die early. Then you have the yellow light folk. They do what is right for a while, then fall back to old behavior. They cautiously do the wrong thing and then wonder why the outcome is bad. Then you have the green light folk. Every physician likes to have many green light patients. They stop, look, and listen, then make sound decisions about their health. Traffic lights are supposed to make life easier, but if ascribed to people, that ain't necessarily so. I love them all, the red light folk, the green light folk. The green light folk, well, they are my kind of people. I'm Dr. Thaddeus John Bell, closing the gap in healthcare.
And now, closing the gap in healthcare with Dr. Thaddeus John Bell.
An issue that continues to drive noncompliance in medicine is the lack of trust that many African Americans have of their physician as well as the medical establishment. I continue to be impressed with how pervasive this feeling is in the African American community. My own experience with this issue is notwithstanding. Just the other day, I made a recommendation to a patient regarding the addition of a blood pressure medicine, and the patient did not take my advice. I understand why there may be some hesitation. However, I recommend these facts to be considered. Make sure you understand the outcome or what is likely to happen if you don't follow your physician's advice. Ask yourself if you are in denial about what the physician is telling you. And finally, don't let a few extra dollars cost you your life. I'm Dr. Thaddeus John Bell, closing the gap in health disparities for African Americans and for the underserved.
And now, closing the gap in healthcare with Dr. Thaddeus John Bell.
Waiting on the Lord. As a young boy, I can remember my mother saying to me, "The Lord works in mysterious ways, his wonders to perform." Many African American people will not accept medical care because they say they are waiting on the Lord. It is not uncommon for folk to take this attitude when faced with a life-threatening illness, such as cancer. The miracles that God has provided for us is often pushed away because we do not understand and recognize that modern medicine is a miracle of God. The story that illustrates this is that of a man who asked God, why did he not come rescue him in his hour of need from the flood? And God said to him, I sent you help 3 times, and 3 times you passed it by. The miracle of modern medicine, it's your choice. I'm Dr. Thaddeus John Bell, closing the gap in health disparities for African Americans and for the underserved.
Anything else? Thank you very much.